Welcome, everyone. Dr. Morse here. Thank you for tuning in to Eternal Vitality Podcast. We've made it to episode 21. If you haven't been here before, I am a sports and family medicine physician. I practice predominantly in Miami. Sometimes I go up to Jacksonville, Florida. I practice at the Osteopathic Center, and we specialize in regenerative medicine, which translates to treating injuries that sometimes require surgery, sometimes people prefer to avoid surgery, and we use a combination of cell lines from our body or donors to help heal the tissue and strengthen it as much as possible, decrease injuries, improve quality of life, improve strength, and ideally keep you out of the operating room. And not only that, we try to prevent the tissue from getting worse. So we're being a combination of reactive and proactive. This specific episode will be about hip injuries and kind of all you need to know about hip injuries. The episode from last week was about knee injuries, in particular meniscal tears, and I did a deep dive into those. I'm kind of bouncing around to different topics. Each of these I cover extensively. Today's will kind of be a summary of all the different types of hip injuries that are common. We will cover osteoarthritis, what we call bursitis, something that's actually very common that if you're lay and not medical, you might not know what it is, and a lot of the medical people don't even know this. Something called FAI, a femoroacetabular impingement. We have torn labrums, and there's a couple other types that are considered hip injuries as well. This is unfortunately very common. It can be common in younger people. It can also be common as we get older, usually in the 40s, 50s, or 60s. So this will help you to get an idea of what the different options are, what the different types of things you should look for, what the risk factors are, and then what the treatment options are. If you have any questions or any comments, I would love to hear from you. Either reach me commenting below, or you can email me or message me on one of these social media platforms. All right. Without further ado, let's get started on episode number 21. All you need to know about hip injuries, strains, torn labrums, osteoarthritis, and FAI. So 75% of people who present with a hip injury to the front, to the groin, pain in the groin, it is going to be one of two injuries, either a torn labrum and or osteoarthritis. Every once in a while, it can be something else, but more often than not, that's what we see. Now, I don't know if the data is exactly 75%. That's roughly what my gauge is. And I've been doing this for 7-8 years now. As far as the posterior approach or posterior pain, I've had two in the past week, which is a little strange because they're usually not that common. It can be hamstring, it can be spine, it can be labrum, and it also can be arthritis, but it's not as common in the back. When you look at this stuff, you think, well, this could be bursitis, this could be what we call snapping hip syndrome. You could have a fracture. You can have referred pain from the tailbone, which happens a lot. You can have a proximal hamstring injury because they're very similar. The location of the hamstring and the posterior labrum are very next to each other. So when people tell me they have pain in the groin, pain with walking, pain at night or resting if they have to sleep with a pillow in between their legs, especially if they're a side sleeper, that's usually when it tells me, yes, it's a hip injury. Sometimes they'll have stiffness. I do hear patients complaining that it radiates to their groin. That's pretty common. The knee doesn't classically go to the groin. It's more like the groin or the hip goes to the knee. You can have a lot of crossover from the spine. We do see a lot of spine and hip. Sometimes it's hard to differentiate what's causing what pain. When you do an evaluation, you can usually isolate the hip and kind of reproduce that pain. And there's a couple different locations traditionally that people have pain, either directly in the groin. You can have it posterior, kind of in the middle of the butt, it feels like, or you can have it laterally at the gluteus medius insertion point. And we'll talk about those in a minute. Now, the anatomy of the hip is more of like a ball and socket. So the ball-shaped femur, or leg bone, upper leg bone, fits into the acetabulum or the hip socket. Now, if you're thinking about it like this, there is a thick labrum, we'll talk about in a minute, that's a horseshoe-shaped cartilage structure that basically holds that labrum into place. Now, when we see that, traditionally, we are going, if this is not stable, then we can have rubbing, we can have itching, we can have all types of stuff. So there are 5 major groups of muscles that actually cross the hip. You have the hip flexors, you have the hip extensors, you have the abductors, the adductors, and then what we call the external rotators. Many of these are very small muscles that are very hard to inject because of where they're located, but they are a lot of moving parts that contribute to the hip. Now, there are 3 major ligaments that make up what we call the capsule. So surrounding the labrum is kind of like a thick fibrous capsule, and that's the iliofemoral, ischiofemoral, and then pubofemoral. The labrum essentially works as a suction seal, and you can see that here that you can tear it. If you took the hip out and look at it, noon would be like the top of the hip, 3 o'clock would be like the front of the thigh, 6 o'clock would be kind of like pointing straight down, and then 9 o'clock would be in the back. Traditionally, we tear these around 2 o'clock. That's usually where they tear these in the hip. Now, in the shoulder, which also has a labrum, that is a much more variable. Often 12 to 3 is an injury, but you can also have it from 9 to 12 in the back. So the hip is much more common directly in the front because we're bipedal, we're upright walkers. Now, if you have someone, if you lay down on your back and you have someone lift their leg up or straight leg raise and then bend their knee, if it starts to get tight as they bring that leg up, they have hip issues. If they bring their leg up and then rotate it outwards and they feel fine, that's a good sign. Sometimes that will correlate with back. That's called a Faber, F-A-B-E-R test. But more importantly, if you were to bring that up and bring that knee towards the other hip or towards the other knee, and if they have significant pain or restricted range of motion, or if they jump off the table, the bed, then you know that they have a combination of arthritis and or a labral tear, or something's going on in the inside of their hip. Now, when that happens, traditionally, we know this is classic hip injury. If you can't reproduce the pain, then it might not be hip injury. It may be something else that just feels like the hip, maybe spine, maybe the lateral part of the hip that's not in the joint. Now, if you were to feel the sides of your leg as it starts to taper in right before your belt line, we have a thick knobby area that you can kind of feel. That's a little bone that's called the greater trochanter. That is where a combination of tissue sits. Now, if you're looking at it from a front approach, the quads actually attach there. Now, if you're looking at it from a side and from up underneath, that's traditionally where people, what we call bursitis, it's actually not bursitis, it's a tendon injury, and I'll tell you about that in a minute. But that is where the gluteus medius actually attaches. And that's classically, you push that and like, oh, don't do that. Yeah, that tells you that that tissue is not happy and is banged up, is injured. Some people, if they have a labral tear, they will have clicking. They will have snapping. They will have catching. They can have like a lightning bolt in their leg, or it may only be one specific position where they put their foot and they end up getting like a very uncomfortable pain. And that's usually because the femur is rotated and rubbing on a very specific part of the acetabulum, and that's usually where the cartilage is worn down. And when that happens, they get this kind of sharp pain. Now, for a labral tear, you can almost always confirm it by exam. Ultrasound doesn't do a good job because you can't see through the bone or deep into the bone. And CT is a little bit overkill and has too much radiation. X-rays are not going to show you exactly what you're looking for, so pretty much for this one, you're good at getting an MRI. Now, if you use a new MRI, like one of the high-level 1.5 Teslas or the 3 Teslas, you really should not need a contrast. Remember, contrast is a heavy metal, usually gadolinium, and everybody just assumes that our body gets rid of gadolinium, but it doesn't. It doesn't always just leave. And sometimes now you just injected a heavy metal into your body on purpose and now expecting it to not cause issues. So ideally, it gets 100% release, but that's not always the case. I've had patients who haven't had MRIs in 5 years and now have gadolinium still in their system, probably causing issues, and that's not something we traditionally get in our diet, so it was likely from that exam. If you have a choice and you can get a 3 Tesla MRI, that's the strength, and you should not need to get a contrast IV with that or inject it into the joint, because the quality is really good. You don't really need that. If you're doing a poorer one or a stand-up one or something like that, then you might need contrast because you're not going to be able to see it. Now, let's talk briefly about a hip flexor injury. So hip flexor is actually very common, and it's more what I call annoying than concerning. This is traditionally in runners, whether they're traditional runners or running on, like, say, an NFL field or a football field, and it's where the quadriceps muscle attaches to the front of the hip. It's kind of like almost on your belt line, just below it. And people say, this spot drives me crazy. It's usually when they start picking up their leg to run or walk. And as they pick it up, it starts to bother them. And if they get high enough, it won't bother them because the tendon is no longer being fired. Now, there's 3 tendons that attach there. I usually inject this pretty regularly. And you can see if it's partially torn or if there's inflammation in there on an ultrasound. It's right underneath the skin. But it's usually pretty obvious when you feel it. You can tell there's a lot of just weird tissue there. You can tell the tissue is not healthy, especially if it compares it to the other side, which may not give them any problems. Now, when I talk about hip bursitis, this is often a misnomer, meaning it is not actually the correct diagnosis. A bursa can get inflamed. Think of a bursa as a fluid-filled sac, almost like a pillowcase. That's goal is to protect a tendon from rubbing on a bone or something like that. And if you think about it, that tendon is supposed to attach but not really rub. So the bursa is there to really protect it from kind of fraying down. Now, what can happen is you can have acute bursitis where that rubs onto the bone, creates an acute inflammation, and now you have that pillowcase, but now it has a pillow in it. So it's much larger and angrier than it previously was, especially if you have a tendon that's pressing it down, even to making it worse. Now, this can classically happen in the hip, can happen in different parts of the knee, and it can also happen in the shoulder. Those are the most common areas. You can bang it in the elbow as well. So in general, bursitis of the hip is not usually the case. This is actually usually an injury to the tendon. Now, the gluteus medius tendon sits between the buttocks, which is gluteus maximus, and the gluteus minimus, which is the closest to the bone. But the medius is the most important, and it's also the one that picks up your leg and rotates it. It goes from the back part of the hip along the back of the pelvis, almost feels like your low back, but it's actually on the hip. And then it rotates down and it attaches to the side of the femur. And what it does is it picks up and it rotates your leg. Well, this is something that can be very painful. This is traditionally more kind of as the leg starts to rotate backwards towards the butt. And you'll feel it if you push deep into this area and you're like, that's my area. That's where my injury is. Classic in runners, I had this years ago when I was doing a lot of deadlifting in more of a little bit of a wide stance, and it just did not feel good. I likely injured that tendon because it would just throb and throb and throb, and I would push down on it really, really hard, and it would finally calm down, but eventually it would come back. Now, if you want, you can see this with ultrasound. It's really clear if you know what you're doing. You can get an MRI of this. It will be obvious that you'll be able to see that there's something going on over there. And this tendon can be anything from inflamed or tendinitis with acute inflammation to a tendinosis, where it's just more of a chronic injury, or a partial tear. Full thickness tears are pretty rare in this area. But partial tendon tears, I had one yesterday. They are awful. They can cause a lot of problems. And if you think about it, if the hip is a ball and socket joint and everything has to go perfect for that hip to move, what happens if this part of the tendon isn't strong enough to pick out that leg? Then you're going to have some issues with rotating that leg. And now you're going to have compensation injuries. You're going to have rubbing on different tendons. And things are just going to be all out of sorts because that tendon is not strong enough to pick that hip up and rotate it. Now you can do physical therapy for this. Sometimes deep tissue massage can help. Cortisone, they do like to put in this area, but in my opinion, it is not really going to help with the injury per se. It may make it feel better, but that cortisone is not going to improve the quality of that tissue. And if that indeed is a partial tear of the gluteus medius, it will make that tear a little bit worse and a little bit weaker. In my opinion, this is a very easy injection for something along the lines of PRP coming out of your blood or a stem cell line, depending on the severity of the injury. This works really well. It does take a little time to resolve, but within a couple weeks, you will start feeling better. Within a couple months, you really won't even think about it anymore. You can have surgery on this. It's really uncommon, and this is usually from scar tissue from that tendon being beat up. Now let's talk about the most common injury in the hip, or at least that people think about, and that's osteoarthritis. Now osteoarthritis is not as common as knee arthritis. You're thinking about 88 people out of every 100,000 versus for knee arthritis is 240 people, so about almost a 3-to-1 ratio. Now, there are several risk factors that play a role in hip arthritis. Female anatomy is one of them. Older age, which makes sense. You're using the joint a lot more. And then trauma to that hip, muscle weakness to that hip, heavy physical stress, and also high-impact sporting activities. Now, you could have things like genetics, hip dysplasia, which we're going to talk about in a minute, as well as something called femoroacetabular impingement, or FAI. You can have a leg length discrepancy, which I actually see quite commonly. This can lead to hip issues. This can also lead to hamstring issues as well. And then obesity does play a role. Or body habits. If you have a lot more weight, you're going to have to move a lot more weight, and that joint has to move more weight, and it's probably going to take a bigger beating. Now, classically think of this as an injury to the cartilage of either the top of the socket, the ball, or the actual acetabulum, which is where the socket is, where it goes into the ball. And a lot of the times you will have wearing down of that cartilage, and think of it almost like shellac or paint on a door, where the wood is the bone and where the paint is the actual cartilage. Now, if the cartilage is injured, you will start to see that paint chipping of that cartilage injuring, and that starts to show you the bone. And when that happens, you start to have a lot of issues with that bone. You start to have a lot of issues, pain, swelling, aching, throbbing, sometimes difficulty sleeping, sometimes difficulty walking. And if you move their hip, they'll have less range of motion on that side than traditional. If it's bilateral, then obviously they're going to have some less on both. For this, x-rays are pretty obvious. You see this, you're like, hey, there's no space around that joint. It's basically sitting on the other, or even worse, you traditionally see this on the side or the bottom, not so much the top, because we don't walk upright. And you can get an MRI. It will tell you the quality of the cartilage and other things going on. But it's not 100% necessary, in my opinion. If their exam is obvious, if their x-rays are obvious, they have some form of arthritis. The question is how much damage else is going on. And really, if you're doing a hip replacement, it doesn't quote unquote matter, because you're just replacing the hip anyway. It's a moot point. Now, one of the things that flies under the radar that I see very common, and is very common in professional athletes and even younger people, is something called FAI. Now, FAI is a femoroacetabular impingement, which basically means that there's an abnormal contact between the head of the bone, the head of the femur, and the acetabulum. So there's a couple different types. I'll tell you about that in a sec. But this leads to torn cartilage, torn labrum, and just pain that gets worse and worse and worse. This often, in my opinion, correlates with activity level. If they're really active in their teens and 20s, they're going to have a lot more issues if they have this than if they weren't as active. I've seen people that have this in their 60s or 70s. They weren't very active and it never really bothered them. I've also seen this in a 14-year-old who was riding horseback and had a bad labral tear in the hip that had FAI that predisposed her to having that labral tear. Now, there's three types, really two different types, and then a combined type. You have something called a cam deformity or cam impingement, and that basically means that the bone, the head of the femur, the head of the leg bone, instead of coming up and tapering before it attaches and goes into the hip socket, it doesn't taper. So therefore, it doesn't have the clearance that it normally would and starts to rub on that bone, causing that wear down of that cartilage. Now, the second type is what we call a pincer deformity or pincer impingement. And this basically means that in the acetabular or the side of where the hip is, there's extra bone or bone spurs basically kind of overhanging. So what happens is when you move your leg, you have a tearing of that cartilage. Now, the most common type, I mean, up to 80% of people, is a mixed type, meaning you have both of them. Now, in my opinion, this is the body's way of compensating. Your body is sensing instability, so what does it do? It creates bone because it can't create new ligaments or tendons to stabilize that hip. But that bone's not supposed to be there, so what happens? It causes new issues. Now, you can undergo what we call an osteotomy, meaning you basically remove a lot of the extra bone, but what are you doing? You're removing the stability of what was there. You're removing what the body did to stabilize it, and you just made it more unstable. So yes, your symptoms are going to get better, but you're going to have issues again eventually. Now, we see this a lot in professional hockey players because of the nature of the skating and how they move. And when those guys almost never undergo surgery, they all do rehab and probably some injections. Now, there's a couple things you could potentially do for this. Obviously, you can take your ibuprofens or Aleve, but that's not directly treating it. You can put a cortisone injection into the hip, classically through the front. And that will help. It won't make it go away per se. It's not fixing the cam deformity or the FAI, but it will definitely calm down the pain. Now, my personal favorite approach, as opposed to surgery, is to repair and address the entire hip. Whether it's, I did one yesterday, so I'll describe to you how I do these. So I do one in the front of the hip, under ultrasound guidance, into the socket. I do one at the proximal femur where that attaches. I do the lateral part of the hip. I inject that bursa or the tendon where that one's located, and then I inject the posterior where that glute med attaches, as well as the posterior capsule and posterior labrum. So there's a lot of parts. You can't just do one little part and say it's going to magically heal and feel better. You have to hit the front, the side, the back in order to collectively make that thing strong altogether. Now, in my opinion, the more active someone is earlier in their life, the more likely they're going to have this if they're predisposed to this. If they're not predisposed, it doesn't matter. I don't think it matters. The other options for people that have hip issues, anti-inflammatories, something like tramadol, which is not a good solution, but it's an increased, stronger narcotic. You can use a cane or a walker. And then you have, if you're a little bit overweight or obese, then weight loss would be a good idea. Modifying your activities, avoiding certain types of exercises. Obviously, something like a box jump or, maybe the rotating treadmill, stairs that are on the treadmill. If you have hip injury, that's probably not going to be a good activity for you. And then some people can't even ride a bike. It bothers them that much where they can't get their leg up. But in general, you should exercise. This will help you more than it will hurt you. Physical therapy can be very, very effective for hip conditions. Sometimes it's not enough. Sometimes it needs to be complemented with either surgery or an injection. And then cortisone can be very helpful. It is not usually a solution per se, but it can definitely help with the symptoms. And finally, gel, which is usually used in the knee in the form of hyaluronic acid. I've done it in the hip. It's not covered by insurance in the hip. I've had some people say, yes, it does help. I don't think it helps as much as the knee, but I can see the use for it, and it's not, it's a relatively easy injection. Now, the regenerative medicine options, which is my specialty, work really well. You do need increased volumes, and oftentimes you do need to do them multiple times because this is hard to fix with one round. But you can break up the scar tissue. You can stabilize that hip. You can get that glute med firing properly. You can get that quad to appropriately fire, and you can get that labrum to feel better. Now, will it ever be 100% like pre-injury with just regenerative medicine injections? No, I don't think I can say that. But have I got people going back with bad FAI and a labral tear playing high-level soccer? Yes, no question. You have to use the right product. You have to put it in the right location, and you have to know what the exact diagnosis is. You can't be just assuming because you're going to end up being disappointed. Now, what does the data show for surgery? And we're going to wrap up with this. Now, in general, hip replacements do better than knee replacements. Now, this is traditionally the recommendation for a bad labral tear with some osteoarthritis, advanced osteoarthritis, or someone over the age of 50 that either fits into those categories. Now, 95% of people report feeling pain relief after replacing their hip. 90 to 95% of those lasted at least 10 years, 80 to 85 at 20 years. That's very, very impressive data. They did have some issues 20, 30 years ago with different types of metals that caused problems. We do not see that anymore. In general, hips do really well. There's different types of approaches and techniques but in general, they do really well. Now, for a labrum, now, you can do a labral repair, which is basically suturing that labrum back together. And for the most part, they do well. Some people do not want to wait because it takes about 3 to 6 months to finally get feeling better before you return. But you're pretty limited, no limitations after you return. About 85 to 90% of people who have had labral repair are happy with it in their hip. But if you do something called a labral debridement, that data is not as good. Only about 48% of people at the 7-year mark were happy with their surgery. So if you're going to address your labrum, have it repaired or consider injecting it. Physical therapy is important. If you're overweight, consider using your weight. And cortisone, while it may be temporarily effective, is not really going to move the needle a whole lot in the long run. It may buy you time. In general, that's the gist of the way I approach the hip. I hope that was helpful for you. It can be relatively straightforward, but it also sometimes can be complicated if it's a combination of different injuries. But in general, you can get them better with non-surgical options. And these can be very debilitating. They can cause a lot of instability. They can cause people to not feel confident in walking. You can have pain in the groin. You can have pain with sleeping and requiring a pillow or tossing and turning and making people sleep on their back, which they hate. Some people do. So this is unfortunately a relatively common problem, similar to knee arthritis, that can make people very frustrated. So if this is something that that applies to you or someone you love, hopefully this information was helpful for you. If you have any questions for me, please put them below. I would love for you to share this information and content with someone that you might find it helpful. This is something I'm passionate about and something that I do weekly. So if you haven't checked out any of my other podcasts, I recommend that you start checking them out. There's a bunch of different ones based on aging and sports medicine and all different types of health optimization. And I'm always looking for different ideas and things that I'm trying to share with you to give you more information and a different approach, whether you are a medical student, whether you're non-medical at all. That's part of my goal is to give information and help educate from a different perspective based on the way that I've learned it in things I see in my day-to-day practice. Thank you for tuning in. If you like this type of content, do me a favor, consider giving a review. I would appreciate that. Thank you very much. Have a good night. We'll see you next week.